Good afternoon, everyone, and thank you for joining us today for our webinar on providing navigation services for clients with serious mental illness and chronic physical health conditions. Next slide, please. This is the second webinar in a series of 2 webinars on navigation services. The first webinar on assessing organizational ability to provide navigation services was held last week, and a recording will be available soon. Today's webinar is going to be interactive with 45 minutes of presenter-led discussion, followed by 15 minutes of presenter and participant discussions. There will be an opportunity for questions and answers at the end of the webinar, so please submit your questions to us using the chat function throughout the webinar. A copy of the slides and a recording of the presentation will be made available at resourcesforintegratedcare.com. Next slide. The Centers for Medicare and Medicaid Services is accredited by the International Association for Continuing Education and Training. The Centers for Medicare and Medicaid Services complies with the ANSI-IACET standard, which is recognized internationally as a standard of excellence in instructional practices. As a result of this accreditation, the Centers for Medicare and Medicaid Services is authorized to issue the IACET CEU. Next slide, please. To earn continuing education credit for this webinar, complete the post-test through the Centers for Medicare and Medicaid Services Learning Management System and score 80% or higher by midnight on September 18, 2017. More information is available on resourcesforintegratedcare.com. Next slide. The Medicare-Medicaid Coordination Office in the Centers for Medicare and Medicaid Services ensures that beneficiaries enrolled in Medicare and Medicaid have access to seamless, high-quality health care that includes the full range of covered services in both programs. To support providers in their efforts to deliver more integrated coordinated care to Medicare and Medicaid enrollees, MMCO is developing technical assistance and actionable tools based on successful innovations and care models, such as this webinar. Next slide. This webinar is developed by the Lewin Group and hosted by the Medicare and Medicaid Coordination Office, Resources for Integrated Care, or RIC. Next slide. My name is Alana Noor, and I am a Federal Health and Human Services Consultant at the Lewin Group, and I will be helping facilitate our webinar today. I'd like to take a moment to introduce our 4 speakers for today. Dr. Alice Geis is the Director of Integrated Health at Trilogy Behavioral Healthcare, a community mental health center in Chicago. She is an assistant professor at Rush University, where she teaches in the master's and doctoral programs. She is board certified as a psychiatric mental health nurse practitioner with doctoral preparation in systems leadership nursing. She has held a number of clinical, administrative, academic, and consulting roles, including director of a hospital-based psychiatric home care program, member of the United Nations team investigating war crimes in the former Yugoslavia, and program development consultant. Kimberly Smathers has been employed by the Lewin Group, a healthcare and human services consulting firm, since May 2013 as a Federal Health and Human Services Managing Consultant. From 2008 to 2013, she was employed as Vice President of Business Development at Heartland Health Centers, a Chicago area federally qualified health center. Ms. Smathers leads efforts to support behavioral health organizations and providers in delivering behavioral health and other health services under the technical assistance to support providers in providing care to Medicare and Medicaid enrollees, contract with the Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. Lori Carrier is board certified in both family medicine and psychiatry. She is currently the Chief Medical Officer at Heartland Health Centers, a collection of federally qualified health centers based in schools, mental health centers, and the community on the north side of Chicago. Previous to this, she was the Director of Behavioral and Integrated Health since 2012. She works with an underserved population, including a large percentage of refugee and immigrant patients. She is an assistant professor at Northwestern University's Feinberg School of Medicine in the Department of Family and Community Medicine. Dr. Carrier's interests lie primarily in the integration of medicine and psychiatry, and she is thrilled at the opportunity to work in several different settings where this is taking place. TJ Thurlow is a community integrated health nurse at Trilogy Behavioral Healthcare and Rush University College of Nursing Office of Faculty Practice. TJ graduated with a master's degree in nursing from Rush University. He has worked on an assertive community treatment team. During that time, he created tools for tracking and monitoring a variety of health parameters for his caseload, including tracking coordination of care, referrals, and educational needs. Currently, he works as a clinic-based integrated health nurse, assisting with team consultations, triage of behavioral and physical health concerns, group education services, and coordination of care for clients. Next slide. To provide a brief overview of our presentation today, we will start out with a few polls, which I will get to in a moment. Alice Geis will provide an overview of navigation services, and Kimberly Smathers will review Rick's navigation tip sheets. Lori Carrier will present on navigating care for clients with serious mental illness and chronic or physical health conditions, and TJ Thurlow will share best practices for providing navigation services for clients from his on-the-ground perspective. We'll then move on to question and answers. So to kick off our polls, let's move to the next slide. Which of the following best describes your professional area? You could take just a minute to answer. Next slide, please. Great, so it looks like we have representation from many different professional areas across healthcare administration, behavioral health, medicine, social work, healthcare management. Wonderful. Next slide, please. Next, we would like you to answer, what is your primary role? Great, if we could show the results. Next slide. And again, many people who are care coordinators or managers, but a variety of other primary roles. Excellent. Next poll question, please. And lastly, in what setting do you work? And can we share the results? Next slide, please. Great, and again, many people from managed care organizations, federally qualified health centers, community-based organizations. Thank you so much, everyone. Glad to have such wonderful representation across the board. Next slide, please. To provide an overview of the learning objectives for today, after today's webinar, you will be able to identify key functions and services that navigators can provide, identify tangible steps to support individuals with serious mental illness and chronic or physical health conditions, and recognize ways to facilitate conversations with clients using RIC navigation tip sheets to manage chronic illnesses and serious mental illness. Next slide. At this time, I'll turn the presentation over to Dr. Geis. Alice, please go ahead.
Hi, I'm Alice Geis. Thanks for joining the webinar. I look forward to your questions and comments at the end. Next slide. So what exactly are the key functions and services of navigation? What is it that we expect navigators to do? Competencies should include these things: supporting linkages with providers, yes, but also transportation, housing, food necessities. Modeling advocacy and coordination of care. This might mean doing the needed coordination or teaching the client or other staff strategies for doing it. Good illness self-management requires both knowledge and self-advocacy skills. The tip sheets you'll hear about later are one example of how basic information can be communicated to clients at an appropriate level. The need for more intensive communication is necessary when working with a vulnerable population in a sometimes fragmented health system. Navigators need to be able to do this. Lastly, navigators provide wellness and health promotion services. One note about wellness: while we include this in our discussion of navigation, it's fundamentally different from the other tasks of navigation in that it involves treatment. However, historically, these treatments are ones that have received limited or no reimbursement, making them inaccessible to most people. I'm talking about weight management, smoking cessation, training in safe exercise regimens. We'll talk later about who does which piece of navigation. Wellness services look different depending on the level of the person providing it. And undergirding all of this work is the need to be able to develop and maintain positive working relationships with clients. Next slide. So why is it important to have the capacity to offer navigation services to people with a serious mental illness who also have long-term medical illnesses? Many individuals, including people with SMI, are members of vulnerable client populations and need assistance with navigation. This might be due to symptoms impacting endurance, cognition, or affect regulation. System issues which make the need for navigation more pressing include our increasingly complex delivery system and other barriers to integrated and coordinated care. When thinking specifically about people with SMI, the importance is magnified by the high rates of medical and substance use comorbidities and the high incidence of premature death due to modifiable risk factors. We also need to align with the recovery model and client-centered care principles, as these have become central to our work. So take the example of tobacco dependence. Tobacco kills half its users across the world, and smoking rates are higher in the SMA population. Or consider what we've learned from the ACE study, the Adverse Childhood Experiences study, and follow-up work to that. Our clients tend to have histories of trauma. A person with an ACE score of 4 is 260% more likely to have COPD than a person with an ACE score of 0. Next slide. For those of you who attended the initial webinar in this series, you would have been doing some thinking about your organization and how well it supports the process of helping clients navigate healthcare. We talked then about how certain things are necessary in order to support such services. While this isn't the focus of today's presentation, I want to just mention some of these factors, the prerequisites for great navigation services, if you will. You need system support for navigation, leadership, resources, including adequate financial resources, and workforce and training development tools. The navigation organizational tool can help you perform a self-assessment and help guide an action plan to create or improve these elements. Next slide. I can give a quick example of how system support works. We did a system-wide intervention to move to a smoke-free campus. Smoking had been allowed outside the building on agency property and banned inside for many years, but all staff as well as the client council were involved in this. One of the interventions that we set up was a small area specifically for people who were trying to quit smoking, to meet with staff individually or in groups. This was named the Cessation Station. There was a dedicated phone line to the Illinois Quit line. We had a countdown to Smoke-Free Campus Day in the lobby, a free smoking cessation group offered on site to staff, and other interventions. This couldn't have been accomplished without leadership support to involve all aspects of the organization. Next slide. Okay, so let's say you and yours understand the importance of providing healthcare navigation services, and you have the basic structure for doing so. What are the important elements to make sure to include in your program planning? You need to have the right people, the right tools, and the right framework to offer the best services. Next slide. Using the right people to provide the service means taking a look at your workforce. Peer wellness coaches can accomplish many of the goals of navigation. They do need support from providers or RNs. Integrated health nurses, sometimes referred to as care coordinators, can do an analysis of the client's navigation needs and develop a plan which incorporates direct care needs, informational or teaching needs, health literacy, and other factors which impact the client's ability to receive well-integrated services. Social workers or care managers can use tools like tip sheets, which you'll be hearing about shortly, to support clients' understanding of medical comorbidities. They can provide expertise in resource identification, linkage to psychotherapy services, and more. One valuable outcome of quality navigation is the prevention of overuse of providers in these activities. Some coordination of care must be done by physicians or nurse practitioners, such as consultation about the medical plan of care, but much of it can be accomplished by people at other levels. So it's important to right size and have people working to the top of their license and abilities. Next slide. Having the right tools to engage clients is important. There's a lot to choose from. TJ Thurlow will talk a little bit about some of the ones we've found useful in a bit. Sometimes they need to be adapted to your setting, population, or staff competencies. Some of the curricula or manuals are already adapted for use with people with SMI. It's important to use evidence-based practices to the extent that they are available. These might include manualized curricula or toolkits that can be used for individual or group clinical interventions, motivational interviewing aids, or materials that educate navigators about special consideration for assisting individuals with SMI who have medical comorbidities. Integrated treatment plans are a gold standard for working in an integrated way towards health goals, but realistically, it's not feasible in many settings for all providers as well as payer organizations who provide navigation services to be working from the same treatment plan. This makes having strong navigation services all the more important. From the peer wellness coach to the orthopedic surgeon, the more integrated the efforts on behalf of the client health, the better. Next slide. Here's an example of a couple of tools for working with clients on smoking cessation, and links where you can find them. Next slide. We talked about getting buy-in from leadership, but having the right framework involves more than that. It involves being client-centered, really putting the person at the center of the treatment plan. Using motivational interviewing is very useful in the context of working with clients with multiple complex health problems. And this framework can be used by many kinds of health navigators. It doesn't require someone credentialed at the level of a licensed psychotherapist. Many organizations that work with people with comorbid substance use disorders, as we do, employ a framework of harm reduction. Some folks like to use Prochaska and DiClemente's trans-theoretical model, otherwise known as stages of change. And the overall approach to health behavior change in a behavioral health organization must take into account the impact of psychiatric illness on a client's ability to change. Next slide. Here's an image of the trans-theoretical model. We often go over this in treatment groups and help clients place themselves on the continuum. Whether you use this model or another, it's vital to understand the client's current ability and willingness to move towards improved health in any given area. So many factors can affect this. Rubrics and toolkits and decision trees, no matter how evidence-based, are only useful in the aggregate. Individuals are impacted by multiple factors that need to be taken into account. Besides the obvious, the mental and physical symptoms affecting the population we're discussing today. They are too many to be listed, but include genetics, cultural dietary habits or beliefs, cognitive ability and learning differences, health literacy levels, personal experience in the health system, and trauma history. So those are just some thoughts on how you might look at theoretical models. Now, turn it back to Alana.
Thank you so much, Alice. Next up, we'll have Kimberly Smathers to describe the risk navigation tip sheet. Go ahead, Kimberly.
Thanks, Alana. As Dr. Geist noted, the intersection of serious mental illness and, next slide, please. The intersection of serious mental illness and physical health conditions creates unique challenges for clients and requires navigation staff to understand standards of care for common physical health conditions, as well as the specific physical and social needs of individuals with serious mental illness. The navigation tip sheets are intended to be practical and user-friendly resources that augment a navigator's understanding of the standards of care for chronic diseases that are prevalent in this population and that also encourage consideration of specific challenges and risk factors these clients may face, support targeted strategies for client self-management, and that lists warning signs that indicate the need to engage clinical staff. Next slide, please. The navigation tip sheets are derived from the experiences of behavioral health clinicians, primary care clinicians, and individuals with expertise in implementing navigation services with individuals with serious mental illness. You can find the tip sheets in both English and Spanish at the link on the screen. They cover diabetes, hypertension, smoking cessation, HIV and AIDS, congestive heart failure, and asthma and COPD. We will focus on diabetes and smoking cessation in particular in the remainder of today's webinar. Next slide, please. So this is just a preview of the first page of the smoking cessation and diabetes tip sheets to give you an idea what these look like. We will describe the content of these two tip sheets in more depth on the slides that follow. Next slide, please. The smoking cessation tip sheet provides basic information on smoking and its intersection with mental illness. The benefits of quitting are outlined, as well as potential withdrawal symptoms that might be encountered during cessation. Navigators will be able to reference key points to share with clients regarding impact to health, both on internal organs and external appearance, as well as information on the benefits of quitting, even for older adults who have smoked for many years. The tip sheets also link to additional resources that the navigator can use to bolster their own understanding or to share with clients. And finally, a checklist is included to support what's called the 5 A's of smoking cessation, which Dr. Carrier will discuss in more depth in her section. Next slide, please. The diabetes tip sheet provides basic information on diabetes and its intersection with mental illness, as well as background on common diabetes symptoms and tests used for diagnosis and monitoring. Navigators will be able to reference practical tips for supporting clients in addition to potential early warning signs that they can observe in their client interactions and, if needed, escalate to clinical staff. These might include a fruity breath smell that can be a sign of ketoacidosis, a life-threatening condition, potentially behavioral changes, or issues with feet, such as noticing non-healing ulcers or infections. The tip sheets also include a variety of actions for supporting clients that can be built into team workflows and referenced in preparation for client interactions. For example, the action list includes prompts to provide support for daily glucose testing, if that's needed, to initiate regular discussions about lifestyle choices, barriers, and strategies, and to provide clients with reminders for regular blood work and clinical exams. I'll turn it over to you, Alana. Thank you.
Thank you, Kimberly. Next, Dr. Lori Carrier will discuss navigating care for clients with serious mental illness and chronic physical health conditions. Lori, please go ahead.
Okay, thank you so much. You can actually flip to the next slide. So it's important that the care team, including patient navigators, have resources that support them in understanding standards of care for chronic health conditions in clients with SMI, and that they can address the psychological and social needs in addition to the physical needs. Also important is to be able to notify and engage clinical staff when specific warning signs occur, as Kim mentioned in the sheets. We'll talk about this a little bit more in diabetes. Next slide. Navigators can be particularly helpful in linking patients to the resources that will contribute to success in getting chronic conditions under control. This may include helping to shop for food, prepare meals, get necessary equipment such as scales in heart failure, glucometers in diabetes. It can also help in linking to exercise, complementary medicine, and educational groups for added support. Without access to the appropriate food and prep space, all the medications in the world will not help somebody's diabetes. And without electricity, a nebulizer for an asthmatic is useless. Navigators can be essential in helping the SMI population, ensuring these necessary services are available for them. Next slide. In order to describe clinical utilization of navigation services, we decided to focus on two conditions that greatly affect the SMI population and actually contribute negatively to the other chronic conditions commonly affecting the SMI population. So today, as I mentioned, we're going to focus on tobacco and diabetes. So we'll start with smoking cessation. Next slide, please. What we do know. So smoking is prevalent in the U.S. with 44 million Americans currently smoking. When you ask them, 70% of smokers will say they're interested in quitting, but we know that only 1/3 actually consult a healthcare provider about quitting. If they do mention their interest to a provider, only 1/3 actually walk away with a prescription for pharmacotherapy, and 15% might be handed materials or offered counseling. We also know that without any external support, even people who really are motivated to quit will only be successful about 5% of the time. Next slide, please. Clients with SMI represent 44% of all smokers and have dependence rates up to 3 times that of the general population. They also suffer greater smoking-related medical illnesses and mortality, with smoking contributing to at least 50% of the deaths in these 3 common psychiatric conditions listed here. Next slide, please. There are a lot of theories on why the smoking rates are so high within the SMI population. These include biological predisposition, psychological, and social reasons, but there's also research that shows that providers place quitting as a lower priority sometimes for a patient with SMI. Perhaps there's concern about exacerbating psychiatric symptoms, or if a patient does exhibit psychiatric symptoms, preventative care measures are often taken a back seat. But what we do know is that there's sometimes baseline psychiatric symptoms that will always be present, so we can't use that as an excuse not to talk about smoking cessation or other preventative care measures. Next slide, please. What we do know is that people with SMI actually want to quit as much as the general population and can successfully do so. While they do smoke at higher rates than the general population, their quit rates are actually quite close to that of the general population. With additional support and resources in place, they can be quite successful, and this is really where navigation support can be critical. Next slide, please. As Kim referenced on the tip sheet, the 5 A's for treating tobacco, these are the 5 A's. We expect our providers to actually do the first 3 at every visit. And by providers, I mean family physicians and our family providers as well as the psychiatric providers. No matter what the chief complaint is that day or despite a client's current psychiatric symptoms, we do want to ask, advise, and assess. When we find somebody who is ready, we'll work with the health navigators on the last 2 A's. TJ will talk a little bit more about this later on. Next slide, please. We know a 2-step approach is the most successful of all to smoking cessation. Medications help with the physical addiction, and counseling and therapy are essential to help with the behavior change and psychological dependence. Next slide, please. So what works? And this really can be done and reiterated by anybody working with the client. You really want all team members to be on board. You want to provide an empathic environment, set a quit date ideally in about 2 to 3 weeks, and encourage clients to share that date with the folks around them so they can be supportive. You want to review past attempts, what worked, what didn't, anticipate triggers or challenges in the attempt. Be culturally appropriate, reflecting racial, ethnic groups, cultural values. If a patient is not ready to quit, help the patient with smoking reduction goal. Harm reduction goes a long way, and if you can even reduce by a couple of cigarettes, then the next attempt for a quit is going to be that much easier. Also, it's important for a navigator to let a provider know if your client does successfully quit or cuts down considerably on their tobacco use, as it can affect the level of medication in the patient's systems. And so medication doses may need to be adjusted accordingly. Next slide, please. This slide is just to quickly note that research has shown different outcomes with different treatments for different mental illnesses. So we can't treat every patient the same, and it will most likely take a combination of pharmacological agents in conjunction with therapy to have the greatest success. Next slide. This graph shows the importance of bringing in the troops when it comes to quitting tobacco use. Unassisted, we're at about 5% chance, while with maximum assist, this can be as high as 50%. And don't forget, it's okay to try and try again. We say a relapse is not a setback, but just one step closer to a successful cessation. Next slide, please. So next, you can go on to the next slide. We're going to talk about diabetes now. So these are just some basic, general basics about diabetes. It's a disease that affects how the body uses sugar, also known as glucose, one of the main energy sources. In type 2 diabetes, which is what we'll focus on today, insulin, which is a hormone in the body, does not work well or too little exists. And when glucose can no longer enter into the cells from the bloodstream, glucose levels can get too high. This can then cause serious damage to other parts of the body, including the heart, kidneys, eyes, and the nerves. Next slide, please. So what are the risk factors for type 2 diabetes? Well, being overweight is number one, but risk increases if you all have any of the following: diabetes in the family member, certain races and ethnicities, Native Americans, Hispanics, African Americans, and Asian Americans are all at increased risk. Also, if there's a history of gestational diabetes, hypertension, high cholesterol, vascular disease, or inactive lifestyle, there's also all risk factors. And then finally, unfortunately, anybody over the age of 45 is also at increased risk. Now, it's important to note that the medications we use to treat mental illness, particularly the class of medications known as the atypical antipsychotics, do increase the risk of developing type 2 diabetes. There's a lot of theories on why this is. One obvious reason is because we know it contributes to weight gain, or can, but actually in 25% of cases, weight gain is not present, but type 2 diabetes can still develop. So there are actually several factors at play. Next slide, please. While occasionally diabetes can be controlled with diet alone, medications are often an important part of treatment, but also have side effects, can require regular glucose monitoring, and in the case of glucose-lowering agents such as insulin, can be really high risk. It's always important to have a lot of support and education around these medications. Next slide, please. This is just a slide to show some examples of different agents. While there are some where daily glucose monitoring is not essential, such as metformin, for the others that do lower glucose, it's important to have a stable, reliable diet. And in the event of illness or increased exercise, it's very difficult to manage without significant navigation services and support. So you can imagine a new, a patient who's recently become homeless, their diet's going to change, their exercise levels are going to change, and so it could absolutely affect their medication regimen. Next slide, please. Just as essential as medications are the non-pharmacological treatments. This can include diet, as we just spoke about, exercise, treatment of comorbid conditions, so foot changes, dilated eye exam, smoking cessation support, very helpful, and then immunizations. There are also particular to being a diabetic. And here is where health navigators can also be particularly impactful. Next slide, please. So there are some red flags that navigators should alert providers or the clinical care team to. These include significant changes or trends in the glucose levels checked at home, so whether they're rising or decreasing. As Kim mentioned when she was talking about tip sheets, a fruity smell in the breath alone or in conjunction with disoriented behavior or change in mental status is a medical emergency for a diabetic. Clients should be encouraged to share with their provider increased urination or thirst, weight loss, or fatigue, as these can all be signs of worsening diabetes or underlying illness. Next slide, please. Other things to be aware of: diabetics are at higher risk for heart attacks. Because they are at risk for peripheral neuropathy or numbness in the feet, they might not even be aware or feel a foot ulcer. So navigators can help to look out for these and make providers aware if they occur. And finally, patients with diabetes are at a greater risk for depression. This also applies to a patient who has another mental illness already, such as schizophrenia. And if depression is not addressed, it will be very hard to successfully treat the diabetes. So now I'm going to pass it back to Alana.
Thank you so much, Lori. Next, we'll have TJ discuss some best practices for implementing navigation services. TJ, please go ahead.
Hi, thank you for joining us. Next slide, please. So I just want to touch a little bit on the role of the navigator, and specifically my experiences being a health navigator and a nurse. Some of those items require doing assessments, either initial assessments or ongoing, participating in care planning, trying to engage with the provider and other coordination systems, educating clients either in groups or individual therapy depending on their individual needs, reinforcement of illness self-management behaviors, making sure that they understand like what needs to be done and that they're actually understanding and able to follow through and do those things. Helping manage referrals, motivational interviewing, and then helping support them in choosing medications or understanding how to obtain their medications. Next slide, please. So to talk about a little bit about the integrated health assessment, which is something that we use here with nursing, is we try and assess the key client factors here, understanding their health literacy, their ability to tolerate groups, what their specific health goals are. And so one thing that we really need to focus on is identifying client strengths and deficits. And strengths is sort of an obvious definition, but deficits is anything that is going to prevent or delay a client in being able to achieve their optimal quality of life. This could be an intolerance to group interventions or an inability to read. There are a number of other things that it could factor into this. Identifying external client support systems and then the cognitive level of your client is really important. If you have somebody who has limited eyesight or doesn't has a fourth grade education or never went to school at all, or is an immigrant and has never had any formal education in the United States, these are really important things to identify so that you can tailor your interventions to your patient. Align your goals with your patient's motivations. This is or your client motivations. This is really important to getting on the side of the client and identifying things that they actually want to work on. While we as healthcare providers and navigators would love to see everybody quit smoking or be successful in their diabetes, sometimes that's not the client goal. And so you really need to align your goals with the client's goals, and eventually if they experience some success with you and build some trust, they will come around to maybe identifying some of those things that you want to work with them on. Evidence-based treatments are ideal, as was stated by Lori. Delegate your responsibilities and your for support. Here within our organization, we have caseworkers that see clients far more frequently than we do in the clinic. So getting them to come in and support the clients in the various things that they're doing, whether it be checking their glucose, making sure they're taking their meds effectively, reminding them to get to groups, or making sure they have transportation to get to a support group is really helpful. And this also stems to inspiring others to action. We really want to motivate our clients through our own actions, and showing them that we're really motivated to seeing what they're doing is really helpful for them to be more successful. Next slide, please. So first, I'm going to talk a little bit about smoking cessation. One thing that we do after we have assessed a person's with the integrated health assessment, I like to use motivational interviewing. One tool that we use really commonly here is something called the Readiness ruler, and it, as you can see on the slide, there's a picture of one down on the lower right-hand corner. We ask how confident they are in their ability to make a change and how important that change is to them. This helps us to sort of get to the main reason of why they're quitting. If that reason is external, like my doctor says that I could quit, we find that it's much less realistic for them to be able to achieve that goal, rather than them finding some sort of internal thing or internal motivation. Smoking cessation aids, identifying a support group, finding a medication that might work for them. These are really important features, and these are conversations that we have with the provider and the client together as navigators. Next slide, please. Prescription considerations that make smoking cessation and getting people to be motivated in the moment that can be challenging are obtaining medications for people. Prior authorizations often miss the window of motivation for a client. If they're in the office today and they say, I really want to quit smoking, waiting that 24 or 48 hours for a prior authorization to be processed and approved or denied can often delay somebody's attempt at quitting smoking by weeks or even months. We here use grants and other funds to obtain nicotine replacement therapy and other smoking cessation aids in the moment, so that we can get people started while we're waiting for approval from their managed care organization. Next slide, please. We continue to support people in their attempts to quit smoking throughout the process. Looking at people's goals and rechecking those goals is really important. Providing fact sheet, educational materials like the tip sheets, stating what their symptoms are going to be, what their withdrawal symptoms are going to be, what sort of supports that they might need to be successful. Encouraging them to attend a group if they can tolerate one or are interested in doing that. Engaging with their peers and their other support systems is really important. Following practice guidelines and customizing those guidelines to fit the client's special needs are really important. Making sure that you're available for follow-up. Most people will attempt to quit smoking a number of times. If you can get them to like 3 months or so, they typically face their first real struggles with like reintegrating into the parts of their social circles that often triggered smoking previously. So making sure that you really encourage them to continue to think about their being an ex-smoker and continue to celebrate those milestones with them, either months or years after they've done a successful quit. That was really helpful. Next slide, please. So diabetes management is the next thing that we like to discuss. Typically, on initial assessment, what will happen is a provider will call the client will get a brief assessment from a client or a brief assessment from their provider. They'll call the navigator, myself, into the clinic, and it will be a conversation between myself, the provider, and the client sort of to get an idea of where the client is in this moment and what they're doing, what they're willing to do and what they're willing to try. And so that's where we sort of started to individualize the care plan. Typically, I'll schedule a follow-up appointment after they have finished their appointment with their provider, so that we can do some education. It might be, reviewing diet and exercise. It could be learning how to use the insulin pen for the first time, or how to check their blood sugar even. The next step in there is to initiate any prior authorizations that are required for medication management of their diabetes. That might be anything from obtaining their glucometer or any other durable medical equipment to getting a supply of medications. Next slide, please. Ongoing support and education, reinforcing illness self-management, encouraging them to check their blood sugar and check it often. Assess their understanding of what exactly the blood sugar, like checking their blood sugar, means, making sure they know what hypo and hyperglycemia signs and symptoms are, so that they can assess themselves when they're out in the community and make sure that they are able to access health care in times of either very low or very high blood sugars, which can be medical emergencies. Make sure that if you generate a health plan with your client, and you're encouraging them to make a food log or an activity log or monitor their blood sugar in a log form, it can be really helpful to review that information so that you can compare their blood glucose log readings to their diet and say, these days that you ate pizza for 3 days in a row, you notice that your blood sugars are much higher. What do you think we could do to support you in trying to manage this a little bit better? Sort of eliciting ideas from the client is really important. And then making sure that you're referring them to resources that are going to be beneficial for them. Be that occupational therapy for learning how to cook more healthy meals, psychoeducation, learning more about their diabetes in a group or a personal setting, and then making sure that they have resources and food stability. So if you have a homeless client, making sure that they know where their food kitchens are and things like that. Next slide. And I will pass this back to Alana.
Thank you so much, TJ. We're now going to open the floor for questions from the audience. Thank you for those who have submitted questions already. Please submit any additional questions you may have in the chat function now, and we'll get to as many as we can. Let's start with a question for TJ. What tips do you have for having a good conversation with a provider and a client?
So the best tips that I have are asking a lot of questions, making sure that when you come in that you ask the person about their diagnosis. Try and make sure that it's a conversation that is very client-centered and not as much just the navigator and the provider talking and the client just being present but not being engaged.
Thank you so much. That's really helpful. So this can go to anyone, but maybe I'll start with you, Lori. Are there additional considerations when clients have more than one physical condition, such as diabetes and a need to quit smoking?
I think one of the main things is that you set goals that can address both of the chronic conditions. So we're always goal setting with our patients. We're always bringing in the navigators to assist in that. So if you can come up with a goal that really targets both. For example, instead of the cigarette after dinner, can you go for a walk? That's obviously going to benefit both the diabetes. It's going to, benefit the smoking cessation goal. And so kind of trying to keep them all in the mix and thinking about how one can benefit the other. You can really set one goal that helps to address more than one condition.
Alice or TJ, anything else that you would add?
Hi, this is Alice. Yeah, I think that as the complexity increases, I think we really need to monitor our clients' mental health in regards to this. A number of these medical comorbidities really constitute additional losses, and these clients have already faced a lot of losses. Having a serious mental illness, which often plunges them into poverty and the inability to work. Sometimes family members don't understand and those relationships have been disrupted. Quitting smoking can be a kind of loss in and of itself if that's something that someone has used to aid and abet their social interactions when they, schizophrenia, for example, causes deficits in those areas. So as we pile up the medical comorbidities, I think the sense of loss, whether it's mobility, needing to use assistive devices, needing help from people when you really don't want it, I think we need to be mindful of this and also be mindful of the potential that past trauma is being reactivated. So that then is going to affect the pace of how you work with folks on these very important health goals. I hope that answers.
Yeah, absolutely. TJ, anything else you'd like to add as well?
I think that really making sure that you're aligning your health goals and the things that you want to do with your client to their own priorities. It might be that they don't want to work on something, but you might be able to, through conversation and questions, align it in such a way that you can, like Lori was saying, work on two health goals at the same time, be it like with the example of like taking a walk after a meal rather than smoking a cigarette, or, having that conversation about diabetes and weight gain and medication management. Oftentimes people are really motivated by reductions in like medication loads, so they, aligning it so that you can say, hey, I know you want to take less medications overall. Managing your diabetes or your smoking through exercise and through cessation is going to help you in the long run be able to attain that goal of getting less meds.
And TJ, I'll keep you on the phone to ask you another question. How many patients do you generally manage, and how many encounters would you say that you have per day?
So I typically in my typical day, I typically have, maybe 10, I have encounters with about 10 to 15 people a day. I also participate in several groups where I do psychoeducation, with it either being like depression management or diabetes or smoking cessation, and those I usually have once or twice a week, and I usually am with maybe between 5 and 10 clients at a time for those.
Great, thank you so much. Let's see, I'll turn this one to Alice, but anyone can jump in if they have additional things to add. When someone's discharged from a state hospital, what's the best way to connect them with someone that may be able to support them?
So the question was, when someone's discharged from a state hospital, what's the best way to connect with them?
Yeah, connect them to someone they could support. I'm reading into that, giving them some help with navigation services and managing their conditions.
Okay, I'm not sure I see a difference in type, but maybe just intensity from any other transition of care, from a more acute to a less acute or a less restrictive environment. I think at first it's important to recognize the stress of the change itself, which I think we are often guilty of not doing in healthcare. For example, nurses in hospitals or doctors are fond of giving discharge instructions, and people are so anxious when they're in hospitals. Often they don't remember this, and so I learned that in home health care years ago. But I think getting connected early is really important to make sure that people don't run out of medications. Warm handoffs often aren't possible in that particular situation, but to the extent possible, meeting someone before they make the transition, or certainly shortly thereafter, and letting them know that they're going to have other help, whether that's primary care, psychiatry, specialists, wellness programming, that kind of thing. So basically building the relationship early and connecting with the existing care team and understanding what the trajectory of treatment was in the other setting is crucial.
Great, thank you, Alice. So this can go to any of you. Do you include home health aides as a provider and educate them so they can assist the members?
I think anybody who has the client's interests at heart and the client agrees, in terms of confidentiality, to have involved, any person can be of assistance. So that might be a home health aide in traditional home care setting. It could be a family member. It could be a non-family member, but someone that the client thinks of as being part of their extended family, or someone who's willing to help them, maybe a reciprocal relationship of that sort. So absolutely, but what I think the tip sheets and all of this and what I tried to speak about is to make sure that the level of intervention is correct. Make sure that we're not putting something on someone who isn't educated at a higher level about the biological processes, for example, not putting too much on them, making sure they understand who they can call if they aren't sure how to help the client.
Yes. And again, another one for any of you. What is the distinction and relationship between navigators and long-term supports and services coordinators?
So as Alice spoke to, ultimately the health navigator can be anyone. So we would consider them all navigators still in the patient's, in their world, in their current medical treatment. It would just be at what stage that patient's moving in. So there's a role for anyone who's actually going to be supportive to that patient. Yeah.
Great, thank you, Laurie. Question for TJ. What cessation program do you use with your clients? And is there anything that you use that's packaged like the American Lung Association or the American Cancer Society?
So here within our organization, we have sort of built based on some evidence-based practice and some experience from external nursing resources that we have within the area. We use a little bit of the American Heart Association, a little bit of we use a lot of pieces of a lot of different tool sets, and we integrate them together into one class that we do for our groups here. We have a consultation specialist that developed a curriculum for us. This curriculum goes through a number of steps and phases where people get ready to quit smoking, identify what sort of symptoms that they could experience, set a date, usually 2 to 3 weeks out from the initiation of the decision. That gives them time to make sure that they can have support systems in place and smoking cessation aids if they're going to go with a medication route available from their providers.
Great, thank you so much, TJ. So this is a little bit of a longer question, and I'll leave it open to suggestions from any of you. The person who submitted the question says, I'm a case manager at a county medical center in California. We have a large population of persons with serious mental illness with multiple chronic diseases and that are homeless and use the emergency room as their primary care provider. So our physicians do not deem them as good candidates for insulin therapy, and most often smoking replaces meals. Any suggestions on how to get our population to engage and get involved in their own care?
Hi, we're having trouble hearing the end of the question, but the case manager understanding is works with SMA population who are intermittently homeless and use the emergency room as a primary source of treatment. Is that correct?
Yeah, and they added that the physicians do not deem them as good candidates for insulin therapy, and most often smoking replaces meals. So any suggestions on how to get their population to engage and get involved in their own care?
Oh, okay, so often these folks aren't good candidates for insulin therapy or smoking cessation. How to engage? Boy, engagement is the name of the game, and we didn't talk a lot about outreach today, but that really is a crucial part of navigation and is necessary. You know, when people are using the emergency room and we're trying to engage them, we try to let them know that while they're open all the time, they don't provide the kind of comprehensive care that we do. They don't provide the individualized care that we do. And we may be willing to work through them having, you know, higher hemoglobin A1C or higher glucose for a period of time because we know we're going to have outreach teams going out there and finding them and trying to find them and trying to work with them as we're moving them towards a better treatment set of protocols. So I think having people that are really willing to do that, that have a demonstrated ability to form those engaging relationships is so critical.
Thank you, Alice. Lori or TJ, anything else that you would add?
Yeah, I think that Alice really stated it well, but making sure that you're building those relationships with the clients, particularly ones that are hard to engage, getting them to show up, encouraging them to stop by when they have questions or concerns, making sure that you have space and room available for triage when they want to come in and have questions or have somebody available to do a little bit of education. It really helps to build the rapport with the client, and that's how you can really make sure that you're continuing to support those clients. There's really no wrong door to get them into the space, and just really, I mean, again, just making sure that you're following through with the things that you agreed to on your end, so that they can feel like they're being supported from your side.
And this is Lori. I was just going to talk a little bit about meds in that case too. We have done some really creative things with medications because obviously that's where the health navigators can be so helpful in terms of dosing insulin that would normally be maybe twice a day, but dosing it once a day, having them come to the clinic in the morning and getting it that way, changing the meds to orals, but if you have outreach team going to the houses, checking glucoses at certain times so that you can even kind of dose depending, or giving insulin in the home if you're lucky enough to have nursing that's going out, or assisting patients in giving their own insulin in education. So yeah, that's I just wanted to speak to the fact that we have done some kind of creative things with diabetes medications with the help of navigators in order to get patients' diabetes under control.
Thank you so much, Lori, and thank you all three of you. If you have any additional questions, we will follow up with any that we didn't get to today, but feel free to email any additional questions that you have to ric@lewin.com. We'll follow up with you. Next slide, please. Thank you so much for joining us today. Please complete our brief evaluation of our webinar so that we can continue to deliver high-quality presentations. For more information on obtaining continuing education credits, please visit resourcesforintegratedcare.com. And if you have any questions, again, ric@lewin.com. And thank you so much for joining us today. Take care, everyone.